Hello and welcome back to the Ophthalmic Referrals Series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. In this episode we'll talk about the adult squint and ocular motility clinic. I would encourage you to watch the first episode in this series because it contains the generic information that we should include in any ophthalmology referral, and that will underpin all the episodes in this series. Do please remember that this is how I would process a referral to the adult squint and motility clinic, and you must of course use your own professional judgment and rely also on any national and local guidance and policies that are in effect. If you're unsure, do seek professional advice. The adult squint and ocular motility clinics are typically delivered by orthoptists. Now they will have the option to have an ophthalmologist's opinion acutely on the day if there's something that they're really concerned about, or make an internal referral to be seen at some point in the future. But it's important for you to understand how your local unit operates in that respect. There are a number of conditions which are sent in error to the adult squint and ocular motility clinic, and I'd just like to touch on a few of those. Monocular diplopia, assuming it's not to do with cataract or corneal problems, more often than not will end up in the not otherwise specified clinic because it's pathology rather than orthoptic condition. Athenopia or eye strain, refractive error, anisometropia. Again, these would be dealt with by the optometrist, or if it needs to go into the cataract clinic, then so be it. Undiagnosed thyroid eye disease or unstable thyroid eye disease would normally go to the ocular plastics clinic because they deal with the orbits. And acute cranial nerve palsies are a special case, 3rd, 4th and 6th. 3rd are usually an emergency, same day, and 4th and 6th are usually so acute that they're seen within a matter of a few days. So in the context of this talk, they wouldn't be referred into the adult squint and ocular motility clinic. They'll need much more acute care. As usual, let's start off with the basics. Refractive error and monocular VA. This is something that we would be including in any of our ophthalmology referrals. Symptoms, which are so fundamental, the onset, the duration, particularly is there any diplopia and are there headaches? The personal ocular history is relevant, so do they have a history of squint surgery, amblyopia, perhaps exercises as a child? You then want to do a cover test and describe which eye is affected, which direction it's pointing, and is it constant or intermittent. A motility test with a description of where there may be any incompetence. A pupil test, again looking at neurological investigations. And a comment on the ocular health. Remember, as I said, that these clinics are often staffed by orthoptists. They're not going to be looking at the fundus at this stage, and it can be very reassuring to say that the rest of the ocular examination was normal. Once we've got the basics right, then we may look to upgrade our referrals to the adult squint and ocular motility clinic. The previous visual acuity can be helpful with the date, particularly of course if the visual acuity is reduced at your most current assessment. A description of the diplopia, and this will help to potentially narrow down the cause. Is it horizontal or vertical? Is it worse in the morning or the afternoon? Or is it constant? The effect that the problem is having on the patient's quality of life. Is it interfering with their activities of daily living? If they're driving, obviously that can be significant and that would often need to be reported to the DVLA. Which muscle or muscles do you feel are affected and in which eye? How are the eyelids looking, particularly thinking about 3rd nerve palsies, which of course require same-day care. And the personal medical history. This is really relevant in the context of nerve palsies, but diabetes, vascular disease, trauma, these are all very relevant to the person receiving the referral. And finally, imaging. A fundus photo, and it can be very helpful to look back at historic photos, perhaps a driving license or family photos, to actually demonstrate any change in the status of a potential squint. Thank you for watching this presentation on referrals to the adult squint and ocular motility clinic. Next time we'll look at diabetic medical retina referrals. Thank you.